Antiarrhythmics. You're going to see DOACs again today if we get to it. So just remembering the things that we discussed and trying to keep stuff together. The way that questions are asked this time is not the same way that you were asked last semester, right? Like, this is more like, okay, I gotta put, there's several questions within one question sometimes, right? What class am I looking at? How am I applying this? Where is this going? Clinical use was a big thing, and that was a high miss, like those were high miss questions. And a lot of it was seriously just like, where are you using it? And it had like this long vignette before, and it was literally just saying, all right, how do you use this drug? Or what's the mechanism? A lot of people miss those kind of questions. So like the core concepts, I feel like everybody got, but it was just like reading the question and figuring out what it's asking. So if you want to go over those, we can go over them. If you want to come in individually, we'll talk about it, okay? All right. So our antiarrhythmics, y'all are starting to get into more lectures where you're getting that pathophys and kind of understanding everything, understanding the heart. And so this lecture, we're talking about patients who have arrhythmias or whatever type of underlying condition. There are several reasons how people end up with an arrhythmia. We're going to talk about the drugs where we're helping them, especially when we're talking about like cardioversion and things like that with our patients who have AFib. So if you had the old notes downloaded, please delete those because I have changed them and shortened it a little bit and took out some information on some of the slides. So these were the ones that y'all should have been told, like if you didn't download these today, you have old ones, okay? So download these. Here are your ELOs, same things. Please make sure we're looking at our mechanisms, making sure we understand when we're using the drugs, adverse effects, interactions. Those things are our big, like, bigger, high yield questions that I particularly focus on. Routes of administration, not so much unless I specifically tell you something, like when we talked about like the hypertensive emergency, urgency type of thing, we talked about that. But if you don't hear me specifically like harping on it and saying you need to know this because I'm going to ask you this way, you don't really need to look at it that way. All right, what do you know? So what class of our I think the one that I posted before had all the answers in it. What class of antiarrhythmic is a beta blocker? You can guess if you don't have two. So when we're looking at our classification system, we have what's called the Vaughan-Williams classification system. And there's 4 different classes that we're going to go over, and then you're going to look at the different other additional meds that we have. And I'll give you a good acronym to kind of remember those drugs. So yes, class 2 when we're looking at our beta blocker. True or false, dofetilide requires a 3-day hospitalization when initiated. So when we look at dofetilide, there is monitoring that needs to be done. We'll also talk about sotalol. There's some additional monitoring that will need to be done with that medication as well. And then our mechanism for digoxin, older med that we use, we kind of touched on it before. So when we're looking at our digoxin, can somebody give me the mechanism? Sure, that sounds fantastic. Cardiac glycoside, right? So remember we talked about, when we were talking about digoxin and how it was going to help me like get that bigger like squeeze. So I said more calcium was going to be able to come in so I can have a stronger like squeeze, a stronger pump. I'm digging deep to make sure that I can get that pump that I need. So the sodium, potassium, ATPase is what we're looking at that's being inhibited. Okay, so our levels of calcium going inside of the intracellular calcium will go up, which will then increase that cardiac output that we have. This is just looking at where you're going to hear a lot of our drugs saying that it's hitting on, right? So I have my SA and I have my AV node. My SA node is going to be on the top, and then I remember my AV being under my under that one. So I remember SA literally like this right here. So when I look at my atrium, I say that my A comes before B, and my ventricles are on the bottom. And so looking at your right, and then you're going to your left outside of your body. So when we're talking about this, a lot of the times we're going to be looking at our drugs, which are going to hit on the different potassium, sodium, calcium, and trying to make sure that my rate and my rhythm are staying in sync is what our big goal is in sync. So looking at that, we have our action potentials, right? So after our SA node stimulates our cardiac muscle, what we're expecting to see is some type of contraction occur, okay? So with this, we have our sodium, our phase 0. Some people will start here, but this is considered phase 4, so that's like your resting membrane potential, which we're naturally negative, in a negative state, because we have more of that, our negative resting membrane potential is what we typically call it. So whenever that action potential gets hit, you'll see that there's an influx of sodium, so the cell then becomes more positive, and then you have a slow influx of the calcium. Then you see your early repolarization, where you have more of your positive, your potassium being pushed out, and that's when you can kind of see some of that that contraction starting to happen. And then you have the plateau occurring because yes, you're pushing out the potassium, but I'm also pushing some calcium in. And then your repolarization, which is again now I'm just pushing out my potassium, and then that's when I become more negative, and I'm back at my resting membrane potential, which would be another 4 essentially over here. Okay, so these are our key players, our sodium, calcium, and potassium that we're going to be playing with our drug to say, hey, how can I get them to either stay in or go out to get my heart to do what I need it to do. Okay, so we're going to target typically with our drugs our phase 0 and our phase 3 for the most part. When you look at what an arrhythmia is, we just kind of talked about it, but it's anything that can disturb my normal rate or rhythm of my heart. I don't want anything to come in and disturb those things. If I have an issue with that, especially if it's prolonged, you have some patients who they live like that and they're perfectly fine. They don't have any problems, they're not even symptomatic. You have some people who are going to be very symptomatic, and they may want you to cardiovert them. They may want to stay, and you can sometimes cardiovert a patient and they will go back outside of that normal sinus rhythm that you put them back into. So sometimes we have to cardiovert for people more than once. And then heart block, essentially this is any type of thing that will prevent that SA node or AV node, bless you, from getting their impulse how they typically should, okay? So it's just a disturbance. None of that will be on your exam. This is just to help you when we talk about our drugs, okay? So that was our quick overview. Here is, FYI. Here is your pharmacology portion of it, okay? So now you can refer back to those slides if you want more information about how they're working and to understand the drugs. Because sometimes I know a lot of people will say, well, where is this going? This is what we're looking at, right? So I have my sodium channel blockers, my beta blockers, my potassium, and my calcium channel blockers. These are all of the different drugs that we're going to talk about. All of these are covered and they're classified with our Vaughan-Williams classification system. So when we're looking at this lecture and when you're looking at your exam, you are going to have some questions that are specifically just saying like, hey, what, according to the Vaughan-Williams classification system, what does this look like? Where does this drug belong? What is the mechanism of action for it? Okay? Bless you. So again, we already talked about these ions that we're looking at and essentially saying, hey, how can I manipulate these with my drugs to get my heart back into that normal sinus rhythm? I want it to beat regular, I want to have my normal rate or rhythm. So we sometimes will say we have rate control or rhythm control depending on what medication we give the patient. So as we go through these, you're going to see on some of those slides where it will say rate control, some of them it's going to say rhythm control, so that you know which one you're controlling. The other thing with these meds is that some of them come with heavy side effects, okay? We have older meds that we don't use as much anymore, but it doesn't mean that they're not still drugs that are good. We will still use them. But we have newer ones that don't have as many side effects. And then you have the negative inotropic effects. So yes, I'm trying to help my patient with an arrhythmia, but some of my drugs that I am using to help with their arrhythmia can be pro-arrhythmic and cause an arrhythmia. So we have to be very careful with these, and some of these come with a lot of monitoring because again, you have that narrow therapeutic window. So if I have a narrow therapeutic window, I'm worried about a lot of monitoring. The CASH trial is one that you may hear a lot about, and essentially that was kind of where we saw, hey, these drugs that we are using to treat these arrhythmias may actually increase their risk of death because of the pro-arrhythmic effects that we're seeing from those drugs, okay? So just something for you to see there. And then we already talked about our Von Williams classification system. This is what we're gonna start focusing on as we move forward. So this is again that action potential is showing you a lot of your drugs are hitting that phase 0 and phase 3 when we're looking at what we're targeting for our action potential. So with this, what I want you to focus on is the class and the mechanism of action. If you want more information about the clinical effect that we're seeing happening outside of our clinical use and me telling you it's rate control versus rhythm control, you can look here and kind of see the shifts that are happening with your action potential. That's what you're seeing over here. But again, 4 classes, so class 1, and you have those 3 subtypes, so you have 1A, 1B, 1C, class 2, 3, 4, and then we have 3 other drugs that we also use to help with controlling that rate and rhythm, which we abbreviate as DAM. And some people will say it's class 5. So depending on, you know, how you're remembering it, we'll talk about our digoxin, our adenosine, and our magnesium. Okay. So here, the class, and you're saying, what's my mechanism of action? So how you see these little words that say inactive sodium versus a sodium channel blocker, I'm not worried about that. I want you to know that it's a sodium channel blocker. Okay, not like the super nitty-gritty. When I'm looking at class 2, beta blocker. Class 3, potassium channel blocker. Class 4, calcium channel blockers, okay? So when I'm showing you this over here, that what I want you to remember about this, and I'm going to talk to you, is McDonald's LOLs at bananas and milk. Okay? The reason why we have McDonald's is because they have some salty French fries and stuff sometimes, depending on who was salting the fries, right? So your sodium channel blockers, that's your mechanism. Alright? Your class 2 LOL, remember our beta blockers in an LOL, right? So all of my class 2s are going to be LOLs because they are my beta blockers. Potassium, because we know that bananas have potassium in them, so that can help you remember, right, that is potassium. And then your milk, because we have calcium in our milk, okay? So that can kind of help you go down and say, like, McDonald's, super not healthy, laughs at my bananas and my milk, which are my healthier things, so that you can try to remember your classifications. So here, again, what I want you to remember is the class, your agent, and then which type of arrhythmias you're going to use them in. You are going to see this again as we go through the slides with the each drug. It's going to tell you like what your clinical indications are, but this is like a quick snapshot for you to have it on one slide to say, all right, here's this class, here are the different drugs that fall within that class, and then here are my utilizations or my clinical uses that I have for those drugs. Okay, so we already said that our sodium, we talked about McDonald's. So if you want to try to further remember it, the way that I look at it is like if I were placing an order at McDonald's. So my quinidine and my docetaxel, that's a quarter-pounder, a double quarter-pounder, because you have a D and a Q. With lettuce and mayo for my lidocaine and my mexellatine is my 1B. And then I can't forget my fries, please, with my flecainide and my propicinone. Okay? These other ones, we've kind of touched on them outside of our potassium channel blockers. Right? We talked about beta blockers, we talked about calcium channel blockers. So these 2 are going to be reviewed. Your 2 and your 4 we talked about. We haven't touched on our class 1 and we haven't touched on our class 3. Alright? So however you want to remember them, it is up to you. I like to remember my McDonald's. This is another summary slide to show you where your drugs are working in a picture. You like pictures? Here's a picture for you, okay? This is saying like, hey, this is where my adenosine is working. This is where my beta blockers are working. So you can kind of see in relation to the heart and your mechanism and trying to help you remember your mechanism where those go, okay? I'm not really worried about you super correlating them with the action potential. I want you to know the mechanism that I talked to you about, okay? So looking at these. Okay. There was another trial that we had called the Pharm trial, and what they were doing was they were looking at what is it better for us to do. Is it better for us to rate control our patient, or is it better for us to rhythm control our patient? And this honestly just depends on the patient, what their desire is to have done, if anything, because some patients are perfectly fine and they're not asymptomatic. So when you're looking at your rate control, a lot of these meds are typically easier for us to manage. They don't have as many side effects, and we're just controlling how fast, essentially, their heart is beating. The thing with this, though, is that you do see that remodeling that can occur. Okay, so that's one of the bad things. And with our heart remodeling, we kind of touched on this in the last block. When that starts to happen, we can't reverse it. We can just prevent further increase of the remodeling or slow it down, but we don't want to work out that muscle to where it gets remodeled. Okay, because then I start to have other issues outside of just having more arrhythmias. And then looking at your rhythm control, this is more beneficial sometimes for your patients who do have a lot of symptoms. We'll also see this used with, any age group, especially again with the symptoms. Your big thing is that these medications are a lot stronger. They have a lot more side effects than what we're looking at with our rate control meds. Okay, so again, you're going to see this as we go through. You'll see some slides where it's saying, hey, it's doing rate control, and you'll see some where it says it's doing rhythm. And there's a very few amount of drugs where we have like both of those properties occurring. So, class 1 with our sodium channel blockers. Again, what I want you to know from here is what your mechanism is, and it's blocking the sodium channel. Are the slides different for y'all?
Can you go back to the last slide, ma'am, real quick? Just that last bullet was on the other one.
Which one? This?
The sinus rhythm.
Oh, down here?
Oh, it's just saying that. Just cut off. Okay. I didn't see what it was.
Oh, okay. If they look different, then y'all let me know, because I did catch, and that's why I was like, I saw the old slides up, took those down, so like if it looks a lot different, then let me know, yes.
For the PowerPoint, I have to transfer it to PowerPoint and then convert it to PDF.
Yeah.
And then pass it to Notability in order to be able to see everything that's kind of.
That, I've heard that with y'all your Notability app, you can't directly like download it, or it doesn't work. It's downloaded. I was more so worried about the content. I was making sure the content was right, not to cut off. I know y'all have to cut off. Okay. So with this, again, what I was wanting you to understand here was your mechanism of action. Understand that you're getting the benefits here are your rhythm control. Okay, we're focusing on the rhythm. Hitting more of our phase 0, so that depolarization phase that we talked about at the very beginning. And then we have our subclasses, so the class 1A, 1B, and 1C. Okay, so this is just telling you like what their effect is, because they have slightly different effects on the action potential. So that's why we have those 3 subclasses of class 1. So looking at 1A, all I told you was, hey, I want you to remember the main idea that if we're looking at the sodium channel blocker as what it is. And then looking at your agents that you have, this was our the double quarter pounder, right? So I have my disopyramide or my Norpace and my quinidine, which is my Quinidex. With these, what we're trying to do is decrease how much of that impulse is going through. So I'm using my drug to block. I don't want that impulse to happen, right? So I'm blocking so that I can slow down that rhythm. I want it to slow down. I want it slower, so I have a blocker. Another way that we could say blocker is saying that this was like an antagonist, right? Anything that blocks is stopping it. With this, we want to make sure, and we kind of touched on this a little bit last block, but like if any of your patients have HFrEF, or if we're worried about like them already having any type of a condition that could be exacerbated by decreased cholinergic activity, then we need to watch out for that. So my patients that I was worried about with my cholinergic activity was Alzheimer's. Remember when we were talking about that? So with our patients who have that kind of condition, that underlying condition, we want to make sure that we're watching out for those patients here. And then here you see, like I was telling you before, I can have that pro-arrhythmic effect, right? So I can now cause an arrhythmia to occur. So therefore, sometimes you will see where when you give a medication out of this 1A class, that you're also gonna give a beta blocker in addition to make sure that you're also controlling that rate, okay? So we have rhythm and rate control. Because I could potentially slow something down too much and I have that reflex. So if I put my beta blocker on top of that, I can help keep that balance and I can help keep that reflex under control. Okay, so that's why you typically will see that they're on together, because that increase in the ventricular response is happening. Okay, so I take my beta blocker and I say, hey, slow that down over there. Yes.
Is this an always situation?
Most of the time situation, because again, when we talk about side effects, right, it could potentially happen in somebody and it could not happen in somebody. But most of the time, that is what we would do. We would put them on 2, most of the time. I'll talk to you on break because your face still, we'll talk about it. Okay. So then with your avoiding in your hep breath, right? So my patients who have heart failure, especially if it is reduced ejection fraction, because remember I had my mid and I have my patients who just, you know, they have heart failure but they're not very bad. This is whenever their ejection fraction was less than that 40%. This is where I'm more worried about those patients. Alright, this is just breaking it up and showing you pictures as we go in between. I don't need you to remember anything from this side. So, when we're looking at our drugs, now we're going to specifically look at our 2 medications that we have that we're talking about that is dealing with our rhythm control. So when we look at our quinidine, this was one of our first ones that we had that were in that was in the class, our 1A. And with that, think about our older drugs. A lot of our older drugs have a lot of side effects, right? So again, we already talked about this. Our reasoning for using them though is going to be any of our atrial or our ventricular arrhythmias that they have, that a patient could present with. You have AFib, A-flutter, and then our ventricular arrhythmias are the ones that are usually more deadly for our patients. So we definitely, if we catch those, we're going to treat them. As you see here, which is what we were talking about before, in this drug being so old, you don't see a lot of people on here. I don't think I have ever dispensed this ever. Because we have newer drugs that are a lot better. But because of those pro-arrhythmic effects that we see and that we saw in the studies that we have done and that we continue to do, we don't use them as much. They're not as favorable anymore. Your drug interactions that you see, all I want you to remember is that you have CYP interactions. So when we see CYPs, just remember interactions, watching out whether it's an inducer or an inhibitor, and remembering what happens when I'm in the presence of an inducer versus in the presence of an inhibitor. Okay? So just remember lots of CYP interactions. And then looking at the inhibitor of 2B6. So a lot of different medications can be metabolized by 2B6 and our drug, right? So now my quinidine is inhibiting those drugs from being metabolized. So I do want you to look at the fact that your DIG in concentration increases, and that you also have your warfarin effects increased. Okay? So digoxin and warfarin, if they were taking these 2 things together, we are going to see an increase in the levels of both of those drugs. Okay? So increased effects. More likely to bless you, more likely to have digoxin toxicity, more likely to have that anticoagulant effect, so a higher bleeding risk. Adverse effects of just my drug in general. Again, like I said, you shouldn't really be reaching for this often, but if you do, I tell you a lot of times, nausea, vomiting, diarrhea, most of our drugs have that, right? But this one, you see, that's a high percentage. 30% of your patients are likely to experience that GI essentially upset that could occur. Okay? So make sure that you're remembering that. And then the other thing that's very unique to quinidine is this synchronism that you can have. So they have like this ringing in the ears, they kind of become flushed, and this is unique to this drug. There are a few other drugs that do this as well, but what you're looking at here is synchronism and the fact that you have a lot of nausea, vomiting, and diarrhea in your patients that could occur. We already talked about worrying about those cholinergic dependent patients, right? So this has anticholinergic properties. So with my anticholinergics, I'm going to dry things up. So those are the other effects that we were seeing with some of our anticholinergics. And then looking at your higher doses, that's where you have those pro-arrhythmic effects. So if you're trying to start someone on these medications, they'll typically say, hey, I need a lower dose. This is one of those start low, go slow drugs. Okay? So you start on the lower end and you try to see if you give them the response that you want to get from your patient. And if you don't, just be aware as you continue to increase those doses, you're increasing your risk of those side effects happening. Looking at this depression of your other muscles, just think of this as being like one of those meds, especially if you're giving it with a neuromuscular blocking agent, or you have a patient who's on one of these meds and then they come in for a procedure and you're giving them an NMDA. This is one of those things that can increase the effects of those drugs, and it can increase the weakness that somebody feels, especially if they have like myasthenia gravis, right? I already have that flaccid tone in my muscles as it is. So now I am increasing the risk of that laxicity occurring because I'm depressing their muscles from getting and maintaining tone. And then looking at your torsades, we're going to talk about not the rhythm, the torsade rhythm, but just like a lot of drugs that we have can put a patient into torsades, okay? So I have a summary, I believe at the very end, that tells you some of the drugs that are very common that will cause torsades in your patients. So the more of those that a person has on board, the more likely they are to experience this type of arrhythmia. Because of the way that torsades happen, and we've already said we're dealing with a lot of those electrolytes, right? So we're worried about potassium, we're worried about sodium, we're worried about our calcium. So you see in your patients who have low levels of potassium, if they have low levels of magnesium, we're worried that they have an increased risk of having this torsades occur, okay? Because I'm blocking those channels and I'm blocking different pumps that are dealing with what increases our risk of having those torsades. So hypokalemia, hypomagnesia. Okay, looking at our Norpace or our disopyramide. Same thing with the mechanism. I just want you to remember the bold that it's a sodium channel blocker. And then looking at our clinical use. For this, we are using this for our patients who were refractory. They're not responding to our quinidine. They're not going to respond to our procainamide, which we don't really use too much anymore, like a lot anymore. So this is like our last line kind of thing. So on this, you can put like, make sure you put like reserve, underline reserve. Okay. I'm going to try other things first before I get to this medication. Again, one of those older ones is this entire 1A is like we kind of push them to the side because we have newer kids on the block. The adverse effects, same thing that we talked about before. Our anticholinergic effects are more pronounced in this with this drug. You also have that hypotension. You still have in dizziness, right? Because if my blood pressure drops, I'm very likely to experience the dizziness or the syncope. And then that torsade is still there. More pronounced again with those patients who are going to have low levels of magnesium or potassium. Okay. Okay, new class. So we're still subclass. We're in class 1, but now we're looking at our 1B, still that same mechanism of action, right? The sodium channel blockers. When we look at these, we don't typically use these so much for arrhythmias. We typically are using this class for pain, right? When we hear lidocaine, most of the time we think about lidocaine for like pain. And then looking at mixilotine, this is just the oral version essentially of lidocaine. Because lidocaine has such poor oral bioavailability, and we only have it as like IV, IM, that's why you see that the mixilotine is available. We've tried to find a way to make it an oral. So here, all I need you to know is sodium channel blocker, and then looking at this, you can use it for our ventricular arrhythmias. Typically, we're using it for pain relief. When I'm looking at my clinical use, I already told you that we have it for our ventricular tachycardia. when you start to look at like, ACLS, and when y'all get it more into like your pathophys with this, you'll talk about whether they have a pulse or they don't have a pulse, because your treatment algorithm changes a little bit depending on if there's a pulse or not a pulse. So this one is specifically looking at if they have a pulse, if you're trying to prevent VBIB, so you decide that you want to cardiovert a person, which we'll talk about. But if you decide that you want to cardiovert them, essentially what you're saying is, I want to put this person back in normal sinus rhythm. I want their heart to be how it typically should have. You can try to cardiovert them, and what we'll try to do is keep them in that rhythm, their normal sinus rhythm. What can happen is, sometimes they will slip back into whatever that arrhythmia is that they have. They will slip out of their normal sinus rhythm. So this drug is trying to say, hey, I don't want my patient to go into VFib after I tried to cardiovert them, so I can give them the lidocaine immediately after I cardiovert them to see if they can stay that way. Again, this is if they're in the hospital, right? Because this is IV, I can't send them home with this. Okay. And then looking at your alternative to if it was a pulseless VT, or if you had VFib and not a first line. So what I've been focusing on is asking y'all stuff about first line treatment, first line, and what do you use if something is refractory, okay? So that alternative is like down there at the bottom. Looking at this, we kind of talked about it already with your PK. We don't use this orally because it has poor oral bioavailability. So we don't use this a lot. Most of the time when we're looking at this, we're trying to use it IV or IM. We have our Maxillatine if we wanted to do oral, because we're going to destroy our F. Our F is going to go down so much if we tried to have an oral formulation of our lidocaine. Looking at this for your patients who have any type of hepatic disease, any type of chronic heart failure, CHF, we're going to make sure that we're looking at our package insert, because their dose may need to be adjusted. Don't need you to remember what it is, just know that you're going to go and look it up if somebody has either of those conditions, okay? Looking at our adverse reactions, when we're talking about least cardiotoxic, this is saying that it's not going to be as harmful to our patient how some of our other drugs are, okay? And then CNS, we have several different CNS side effects. So just understanding that as you run this, the quicker you run it, the longer you run it, the more likely you are to see some of these CNS effects occur. So like the nystagmus, where the eyes are moving back and forth, the tremor are very common things that you can see. Contraindication, I don't need you to remember what degree, I just need you to know that we're not using it in our patients who have heart block. Okay? Because y'all will learn all those different degrees and stuff later. And then our interactions, just making sure that you understand that if you're taking amiodarone with your lidocaine, that your lidocaine levels can greatly increase while they're taking the amiodarone. Okay? Maxillatine, similar profile as our lidocaine. The big difference here is that this is going to be our oral formulation. You can see this used in our patients who have had an MI previously, and we're trying to, and they now have some type of ventricular arrhythmia. We can give them this. Again, not something that I see very often prescribed, not even for the neuropathy that we can sometimes see it used for with our diabetic patients. I don't see this used that often. Narrow therapeutic index, so what does that mean for you as a provider? Something has narrow therapeutic index? Monitoring, gotta keep checking their side effects, making sure that they're taking their drug how they're supposed to. So this is also another reason why we don't typically see this one being used. Again, lots of interactions, okay? So just remember we got a lot of sick interactions. And then our adverse drug effects, more of that GI again. That's the most common that you're gonna see are those GI disturbances. So nausea, vomiting, they'll have a lot of gas. So they're just not comfortable. Sometimes what we can do, which is good in this situation that we can do it and it doesn't have that interaction, is that we can take it with food, or you can try to use an antacid to prevent how much gas they're experiencing, or just the discomfort that they're experiencing from the medication. Because some of our meds, you know how we're like, oh, don't take it with an antacid. This one isn't disrupted by that. Same CNS issues, same thing with watching out for the heart block. So essentially the difference between these two was one was oral and one was IVIM formulation, and understand they both have a lot of CYP interactions and grouping them together, okay? Big difference is all you're using the route of administration. Looking at our 1C, so again, still in that sodium channel blocker, that's all I need you to remember. If we're blocking that sodium channel, I'm slowing everything down, right? I'm against that impulse being created. So my clinical use, I can look at my atrial or my ventricular arrhythmias for these patients and then try to get them under control, okay? You see here where we were talking about this pill in a pocket approach. So pill in a pocket approach is, again, something that we look at whenever we're talking about trying to control our patients outside of the hospital. So essentially, whenever they start to feel symptoms, they will reach for that pill that's in their pocket and they will take it so that they can slow down that heart rate, okay? A lot of your patients will tell you that they can feel whenever they're like slipping out of their normal rhythm. Some patients, they don't feel anything different, okay? So your pill in a pocket approach is for those ones where like they're not having it happen very often. They did something, they had some type of activity, or they know that it's exacerbated as they move around more. They have the pill in the pocket approach, we give them that, okay? You see also, again, what we talked about before, if I try to give them this medication and I don't give them something to kind of rate control, like one of my beta blockers, I can see that pro-arrhythmic effect that occurs. Most of the time, like I was saying before, like you will just give them together to prevent it. And if you're cardioverting, these patients are going to be under your care. Like you're going to have them hooked up, you're going to be monitoring their vitals. And then depending on which route of cardioversion they do, sometimes it's the same day procedure. If they don't respond very well, then you can keep them overnight and then we'll let them go. Watching out again for our heart failure post-MI patients, because we can make it to where they have an increased risk of death, and that was again from that cash trial that we talked about at the very beginning that was letting us know like, hey, these drugs can make things worse for these patients also, so we have to monitor them. There are two agents, this was our fries, please, and our McDonald's order, right? So our flecainide and our propofol. Okay. When we look at our flecainide or our Tambicor in specific, we have this now looking at, again, that rhythm control. This is another med that we can use for the pill in the pocket approach if we were looking at trying to quickly terminate the afibrillation that they're feeling, so we can kind of terminate that, the flutter that some of your patients will tell you that they have, okay? Drug interactions, again, remember a lot of CYP interactions, don't need you to remember which one, but specifically looking at your digoxin, it can increase the rate of, or the levels of your digoxin, all right? So make sure that you're looking at your drug that is increasing here. Adverse effects, these look very similar to what we already talked about before. So looking at the fact that you can have, and the biggest one is that your patients who have acutely compensated heart failure, this can become worse in those patients. And then you have, again, the tremor, the nausea, the vomiting, all of those things occurring in those patients. If they already have a history of AFib, you are likely, very likely, to see that A flutter in those patients, okay? So that's why we were talking about potentially giving them other meds to kind of help offset that. When we're looking at this warning, deaths from flecainide were greater than a placebo, okay? That is that pro-arrhythmic effect that we kept talking about, all right? So again, a lot of your class 1 drugs, do we still use them? Yes. How much? Not very often. A lot of the times cardiology is the one who is using them, and they're using them and monitoring the patient very closely. Contraindication, right, because of the increased risk of death, and then that, of course, the fact that we're slowing down that heart rate. I'm watching out for my patients who have heart failure or any type of valvular artery type of disease. Okay, so your CAD stands for your coronary artery disease. Propofenone or Rhythmol. The brand name kind of tells you what it's doing, right? It's helping with that rhythm control. We're still dealing with our sodium channel blockers, okay? So this is looking at your rhythm control in your patients who have any type of AFib, A-flutter. Again, another one that fill in the pocket. I can just take this with me. Adverse effects was different here. We still have those GI and that dizziness, but now I'm telling you about a metallic taste. We don't see that very often with some of our meds. So what some people will tell you is that it tastes like metal or like, now I'm gonna sound crazy. Have y'all ever taken a battery when you were younger and put it on your tongue? That's what it does to you. Like they'll say that it kind of feels or tastes like that in their mouth for like all day, or like they were sucking on a penny. That's how some people will say it. So like they have this underlying metallic taste that's in their mouth. Okay. Adverse effects, or your other adverse effects, this looks very similar to what we already saw previously. So just kind of putting those together, and then the fact like these pro-arrhythmic effects are going to keep coming up whenever we're looking at our 1Cs. Interactions, I see now my DIPS concentration is greatly increased. I don't need you to remember the percentage, I just want you to know what's happening with that concentration, okay? So your digoxin is going up, your warfarin is going up, so now I have a higher chance of bleeding with my warfarin concentrations going up, and then I have my interactions with all my SIPs. Okay? Don't remember the percentages, I don't care about that, I just want you to know which drugs are interacting with. Okay, our beta blockers. So when we look at these, this was our LOL portion, and here we're just trying to block that stimulation that we're getting from the from our beta receptor, so therefore we can slow down or decrease the rate of that those contractions that are happening. So this is one of our drugs that we're using more so for rate control. And when you look at that, that's what that decreased automaticity is, right? Like I'm slowing down how fast that's happening. So I'm controlling my rate with these meds. Prolonging my AV conduction and decreasing my heart rate and contractility, except for my ISAs. Remember we talked about our ISAs, and they were maintaining that normal heart rate, and those were those patients where we would like to use those if we had somebody who had like bradycardia, or we weren't wanting to drop them more. That's where we were using our ISAs for, because those maintain the heart rate. So if we're looking at anything outside of that ISA category, we were going to be decreasing that heart rate and their contractility. So this is our rate control. When we're looking at this, because of us having that the increase in the sympathetic activity, I can also see where I have a tachyarrhythmia occur from that, right? Because I have that stimulation. So therefore, just make sure that we're paying attention to the fact that a tachyarrhythmia occur. We're going to use this also in our patients who have AFib, A-flutter. So if I have somebody who has too much sympathetic activity and I want to shut that down, I'm going to say, hey, beta blocker, block that from happening. Slow that down so that we can have a normal rate. Okay, so my arrhythmia is not as fast. Tachy is where we're telling it, where we're saying it's going fast. AFib, A-flutter, we'll go into some of this about how if we're trying to control that rate, sometimes even when we're looking at cardioversion as a whole, we'll sometimes also anticoagulate that person before we cardiovert that person. Because what if I was in AFib or A-flutter for a long period of time, my blood hasn't been moving how it was supposed to, and then you put me in a clotted, and now you put me in my normal sinus rhythm, and I just push that throughout my body, right? So now I have bigger issues. So that's why sometimes before we do any cardioversion, before we get people who have AFib or A-flutter back into their normal sinus rhythm, we may anticoagulate them. And then looking at your mortality benefit, we talked about this already. This is one of those few classes that we have where we get a mortality benefit. That's why it was like a part of a lot of our backbones on last block, because we have a mortality benefit. And then using this post-MI, this was a part of their like, go home with this packet, right? If I have an MI, most of the time my patients are going to always, for the rest of their life, be on a beta blocker, okay? So, post-MI patients, beta blockers. Adverse effects, same things that we've already talked about before, right? Looking at our caution with our masking with our patients who have diabetes. So when you're looking at this, you're more so worried about this in your patients who have a lot of hypoglycemic episodes. Because if I have a lot of hypoglycemic episodes, meaning my blood sugar is usually low, and let's say you see a lot of times where I'm at like 60 or 50, those patients you're worried about because you want them to be aware that they are now hypoglycemic, right? So if I mask that with a beta blocker, they don't realize that they're having these symptoms, they haven't checked their glucose levels, that's very serious for them, and it makes it harder for them to recover from that episode as their levels continue to drop. So the diabetes and then all these other ones we already kind of talked about before. Looking at our agents that we are specifically looking at, you have your propranolol, which was your non-selective, and then all of our others under there are going to be selective. I don't need you to remember the formulation and like where we're using it. The only one that I wanted you to remember was that you had IV for your esmolol, and it has a very, very short half-life. Sometimes when we push that, by the time you get it to the person and they're like, oh, did it work? It's like a lift. They're really like short half-life. So again, don't try to remember all of these things. What I want you to remember is what's selective, what's non-selective, and looking at your esmolol as being your only one that's IV. And in your propranolol, we do get some of that CNS crossing, so more CNS side effects can kind of sometimes happen with that. Okay, class 3. So now we're at our bananas, right? McDonald's LOLs at bananas, so potassium. When we're looking at this, rhythm control is our big thing that we're worried about here. And what is something that kind of stands out here that we see that kind of is in those agents that look like it doesn't belong? Sotalol. Sotalol, you would think would be in our class 2, right? But when they did this classification, it has more effects on the potassium, so that is why that is your only beta blocker that is classified in class 3. Okay, so that is your big exception that you have. Your other meds that you have, amiodarone, sotalol, ibutylide, dofetilide, dronedarone. Okay, we do see these prescribed a little bit more. They're very good for your atrial and ventricular arrhythmias that you can have. But we have one little flamingo that's standing out there, which is our sotalol. Looking at amiodarone. So amiodarone is a drug that we use a lot in inpatient, but there's a lot of monitoring that comes with our amiodarone. Why didn't y'all tell me what time it was? 1:52. Let's take our break. Okay, so we're gonna keep going with our amiodarone and talking about this med that we use. And like I was telling you, we use it a lot on the inpatient side, and we will end up discharging some of our patients with amiodarone. Again, we're in our potassium channel blocker class now. You see that it has effectiveness over several different classes, but because it has more pronounced and it's more, most of its action is with our class 3 and on those potassium channels, that's why you see it there. So you have class 1, 2, 3, 4, it's hitting everything, okay? But most of its effect is coming from that potassium. Looking at your clinical uses, we're seeing this when we're talking about our pulseless VTAC, and then also with our VFib. You also see this with our atrial and other ventricular arrhythmias. We can use this here, and we can also use it to help us cardiovert some of our patients. We'll look at a little algorithm for that later. And then your left ventricular dysfunction are your patients who have some type of heart failure and they're having issues. We can sometimes see this used there as well. Looking at your contraindications. Okay, these are abnormal, kind of weird contraindications for us to use. So our iodine hypersensitivity, when we're looking at our iodine or hyperthyroid, the thing to think about with this is that when we're making our thyroid hormone, it has iodine components to it. So when you try to remember these side effects, kind of link those together, and then look at amiodarone, IOD. It has like iodine in it, so that you can kind of remember it, IOD for your iodine. So iodine hypersensitivity, or any of your patients who have hyperthyroidism, issues with that extra iodine, this could be a problem for them because of how this medication is made. And then just remember heart block, don't need you to remember the degree, just heart block. Looking at some more of our properties that we have. So you have PO and you have IV formulations. Depending on what we are using it for, we can sometimes try to load our patient with the IV formulation and then give them PO. But understanding that when we're loading these patients with this, sometimes it's a lot of fluids, so you kind of have to take a lot of things into consideration. So cardiology would definitely be helping you with this. When we're looking at this, we'll talk about these when we look at the side effects, but this has a very, very long half-life, okay? So even after we have stopped giving this medication, you see that this medication can be in their system for up to 3 months. That's a long time, okay? Understanding that it has a lot of interactions, all right? So I see that I'm inducing, so if I'm looking at my phenytoin, my phenobarb, or my rifampin, I can see that like I can alter the effects of these drugs, right? If I'm inducing, I can decrease the levels and the effectiveness of those drugs. I have my inhibitors. What I want you to pay attention to here is, and I don't need you to remember the dose because some of your patients are going to be on both of these meds. So when you're looking at this, I want you to look at your statins. Actually, just this line, because I don't want you to get confused by the dosing and stuff. So increases your statins, your DIG, and your warfarin. That's it from there. Don't try to remember doses and all the other things that are under it. It increases the levels of your statin, your DIG, and your warfarin. Okay? And then if I put this medication with a non-DHP calcium channel blocker or a beta blocker, which are also working on slowing down my heart rate, I can have an additive effect, and now I've caused them to become very, very cardiac. Okay, so that's what you're seeing whenever I'm looking at my calcium channel blocker, non-DHP calcium channel blocker, and my beta blocker. Okay. Now, this is all of the monitoring that comes along with amiodarone. Okay. Remember, it has that very long half-life. Up to 3 months after my patient is done taking it, this medication is still built up into their system, right? So a lot of the times we have poor adherence because these side effects occur and people are like, forget it, I'm out, and they'll stop taking the med. So it's very important for you to follow up with your patient to make sure that they are still actually taking their medication. So the first one that we have is going to be our pulmonary fibrosis. So you're going to take their baseline, and every 6 to 12 months, you're going to check them out to make sure that they're not experiencing any pulmonary fibrosis. They're telling you, hey, I'm starting to cough more. These are things that you're also going to tell them to look out for. Shortness of breath. Those are those big things where you're like, all right, I need to be watching out for this. If they tell you that they're experiencing that, you don't say, well, I got your baseline a month ago, you got to wait 5 more months. Check them out, okay? Don't make them wait. They're giving you those signs, they're telling you that it's a potential that it's happening, then you check them because they had the symptom. Liver toxicity. So again, make sure that you're checking those LFTs baseline 6 months. Your hypo or hyperthyroidism, making sure that you're monitoring their thyroid levels, because remember we said that amiodarone, I was worried about the iodine that's in there, right? So that's why I'm monitoring their thyroid, making sure that they are not experiencing hypo or hyperthyroidism. Okay, so baseline, and again, every 6 months. Bless you. The other monitoring thing that you're going to look at is if they ended up having optic neuritis. So they're going to do their ophthalmology exams. Again, typically they're doing baseline, and then if they complain of any visual impairment. But if you're bringing them in to check everything else at 6 months, you can also check this just to make sure. But most of the time we'll tell them, hey, like if you see now, you're not able to read the same way, or you're not able when you're driving to see things the same way, then you come in and we'll do that visual examination for them. This blue-gray skin is not something that you're necessarily monitoring for. It will happen. It can happen in light-skinned people, dark-skinned people. It doesn't matter. You can experience the blue-gray skin. So just make sure that we're understanding, we're monitoring their lungs, we're monitoring the hepatic, the cardiac, the eyes, their skin can change color, so a lot of monitoring that's happening. Baseline, okay, we have to look at the thyroid, but baseline and then every 6 months. If they complain of something happening that falls along in any of these categories, we will test them again at that point. We won't make them wait until that 6-month mark. Okay. Dronedarone. So dronedarone, still looking at our class 3 oral medication, but the big difference here is that it doesn't have that same iodine component that we were worried about in our amiodarone. So if a person is allergic to or they have some type of hypersensitivity to that iodine, or if they have any issues with their thyroid, this medication is not going to cause those problems like our amiodarone was. Okay? So that's the big difference between these two. Everything else is kind of the same. You see the same activity that we talked about before. Their same uses are essentially the same thing. Not as effective as our amiodarone, but I can still, in most of my patients, get a great response. You see that my half-life isn't as long as well, so I don't have as much monitoring as I had before with my amiodarone. And then I have the interactions that are still there, just again, not as many as I did with my amiodarone. Looking at my adverse effects that I don't have to worry about all of that monitoring that I was doing, so that pulmonary toxicity, the issues with my thyroid being off because of that iodine. I don't have to worry about any of that monitoring anymore, okay? What I do need to worry about is the fact that if somebody has heart failure, especially if they're experiencing acute decompensated heart failure at that time, I can see those symptoms worsen in that patient because I'm slowing things down for them, right? Anytime we slow things down for those patients who are experiencing heart failure symptoms, it makes it worse. Our interactions, just remember several interactions that we have, and that if we have something that is going to increase the QT interval, we can potentially make this a lot worse for those patients. So that's like an additive effect because it can worsen that QT prolongation as well. So our contraindications, if somebody already has a prolonged QT, I will just tell you that it's a prolonged QT. I don't need you to remember how many milliseconds, okay? And then with our patients who have acute decompensated heart failure, don't worry about the classification. Just remember if they have heart failure, acute decompensated heart failure, we're trying to avoid our dronedarone. Any block, any hepatic impairment, because I'm worried about my metabolism and all of these interactions, I'm going to watch out for that. If their heart rate is already very slow with most of these medications, I need to watch out for that because I'm going to also slow down their heart rate. That's what all of these are doing. Okay? So we're going to be very careful with that also. Sotalol, remember, this was our one that we will remember as a beta blocker, but it's in our class 3. Okay? So it has both of those effects, but more pronounced and more effective when we're looking at this as our class 3, when we're looking at our Vaughan Williams. So potassium channel blocker is kind of where you're seeing it. You do see that I have that non-selective activity with my sotalol, but again, when we're talking about our Vaughan Williams classification, this goes into class 3. Black box warning was kind of similar to what we were talking about when we did those pre-test questions, where when we initiate this medication, they're going to need to be in some type of facility for us to be monitoring their vitals. If they have been on the medication and they stop the medication, we are going to need to reinitiate it in the hospital so that we can monitor their vitals, okay? We need to be able to make sure that that facility has the ability to resuscitate someone if something does happen, okay? That's the big thing with this. And it is so serious that they have it as a black box warning. Remember our black box warnings were all those serious things that could happen to where they could kill someone. So that's why we have them as a black box warning. Our clinical use, ventricular arrhythmias, and then if we are trying to maintain, or if we have cardioverted somebody and we're trying to maintain that normal rate that they have, we can use our sotalol. Looking at my PK parameters. So what I want you to look at here is that there's not a lot of interactions that we're looking at. Just kind of remember how we grouped our beta blockers together is all essentially the same way that we're looking at these PK parameters also. So a lot from here, I'm not really worried with you about. Like, it's the same things that we talked about before when we're looking at our PK, and also the same things that we talked about when we're looking at our adverse effects. The big difference with that adverse effect that I want you to watch out with is the fact that they could potentially experience torsades in that first 3 days of them using it, which is why we're worried about where we're initiating it. That's where that black box warning comes from. Okay? Everything else remains the same from what we talked about with our beta blockers. The heart block, all of that, the bradycardia, all of those things, asthma, all those things still come into play for our contraindications, okay? So, if my patient, the one thing and the way that we haven't said it here, and remember I told you don't worry about how many seconds because all of these drugs will have different what the cutoffs for their QT prolongation. But with this, because of that 3-day, that black box warning where I need to be in the hospital because I can potentially cause torsades, remember that you're not going to give it to somebody who already has QT prolongation because this is definitely likely to increase our chances of experiencing the torsades. All these things are popping up on my screen. Okay, ibutylide. So when you're looking at your ibutylide, this medication is one of those that you don't see very often, but again, it is a very effective one at stopping those arrhythmias that we have, those atrial arrhythmias. Adverse effects, torsades, that 4 to 8% seems like a little thing, but it can be a very big thing, okay? Good thing is that this is IV and they're usually in the hospital. We can usually see whenever this is happening and we can stop the drug and we can fix that pro-arrhythmic effect that we're seeing that's causing that torsades to happen. Your dofetilide or ticagrelor. So with this one, again, potassium channel blocker, your clinical use that you're seeing, we can use this when we're talking about cardio converting someone who has AFib or A-flutter. Those are usually the people that we're cardioverting. And then we're trying to say, hey, I want you to stay in normal sinus rhythm. We already said this a lot, but like you can cardiovert somebody and they can slip right back out. You have some people who they're like, you know what, keep me out. I don't want to be cardioverted, whether that's mechanically or chemically, which is like with our drug. I don't care, just leave me how I am. I'm not experiencing symptoms. And then we'll go to the pill in pocket approach where we'll say, hey, all right, when you do experience that flutter, or when you do experience like that fibrillation that you're having, you can just take this every now and then because it's not frequent that they're having these exacerbations for them. Good bioavailability, which is why we have that oral formulation. Understand that we don't have a whole lot of interactions, but we do have this black box warning for making sure, again, just like our Sotalol, that we are initiating this in the hospital. Okay? And that's why we're monitoring them for that 3 days, because we're likely to see those pro-arrhythmic effects happen in those patients. Okay? So very similar to your Sotalol, you have your dofetilide, where I need to be in some type of institution to start it. Looking at my contraindications because of the way that I am excreted, I need to make sure that their creatinine clearance is above 20. And then making sure that they don't have QTc prolongation. Your drug interactions, again, make sure that you're just understanding that there's a lot of interactions that are occurring. Don't try to remember all of the specific interactions, just understand there's lots of interactions that are occurring with this med. So if you see somebody that's on dofetilide, you don't need to look it up, okay? Because they have a lot of interactions. Adverse effects, which is again why we're initiating this and we want to have them in the hospital, is that torsades. Again, very similar to what we just looked at in that Sotalol. And because of how much renal excretion we have, if somebody has poor creatinine clearance, what was our cutoff for this drug? 20. So if somebody does have poor creatinine clearance, then we're definitely worried about seeing that torsades happen because now that drug level went up, right? I started to accumulate it. I'm not getting rid of it. I'm not excreting it. So that's why I'm going to be more likely to see this torsades happen. And then this monitoring, we're going to monitor them for 3 days, so like the 3 to 4 hours. That's where we're typically going to see if they're likely to have that torsades happen. And then the diarrhea, they're just throwing that in there because why not? Our calcium channel blockers, class 4. We remember calcium channel blockers. We talked about them. We have our DHP, we had our non-DHP. We're blocking that influx that we had of our calcium. Rate control, just like we talked about our beta blockers, rate control. Okay, so those are our two that we had that we're focusing on rate. You see that we have our atrial, more so getting more effectiveness in our atrial more than our ventricular arrhythmias that we have for our patients. Good medications, tolerated pretty well. And then you also see that when you have your supraventricular tachycardia, these are also very good in those. Your cardiotoxic effects. When we're looking at this, the higher the dose, the more likely you are to see this occur, right? If I block that AV node too much, I slow down that conduction too much, I'm more likely to see my adverse effects occur. We already know this, we talk about it a lot. So if you have somebody who is already on another beta blocker, all of those other things, they have a low, they're already bradycardic, we are watching out for these medications, especially when we're looking at our non-DHPs, because those are more selective for my heart, okay? We talked about the hypotension, especially if we're looking at our DHPs, right? Because those were more so focused on the vasculature. Not saying that our non-DHPs didn't have that, but it was less than just our regular DHPs. So then, with that, you see all of our side effects that we talked about, your headache, your dizziness, all of those things that we saw. And remember, our verapamil was less selective, and we had more adverse effects when we were looking at that. So this is just showing you a different action potential. So this is looking at your pacemaker action potential. And so that's why these phases look a little bit different and why your arch looks a little different. But essentially what you're seeing here is that I'm trying to say, let's block that depolarization that's happening with that calcium, and therefore I can, which opened up in phase 0. So I'm trying to block this from happening, which then reduces the heart rate. It's going to slow everything down. It'll decrease the heart rate. It'll decrease the contractility that they're experiencing. So this is working on the action potential. Okay, so that's what we were talking about with these, with our calcium channel blockers. There's one more thing pop up, y'all. Lose my patience over here. Okay, so same slides that we already saw, right? So you have your non-DHP, we had our verapamil, we had our DILT. This we were looking at our verapamil having more action, right? We were worried more about our verapamil. Here we had less of an effect when we were looking at our DILT. And so same things that we were talking about with our verapamil and our DILT, non-DHP. Our other medications that we were talking about were DHP. So if we're looking at issues that are focusing on the heart, that's why you see us focusing specifically on our non-DHPs versus our DHPs, because those are more on our vasculature, right? So that's why you see your non-DHPs here. This was our DAM, or our class 5, right? So we had our McDonald's, LOLs, and bananas and milk DAM, or class 5. You will hear this either way. So when we're looking at this, we have some digoxin. Digoxin is an old medication. It doesn't help us reduce any mortality. It does help with some of the symptoms. We saw this when we were talking about like PEPRA. We could add digoxin. Our mechanism of action is all the things in purple. So it's a cardiac glycoside, and we said that it was going to inhibit that sodium potassium ATPase pump, right? So that's what we're looking at whenever we're talking about this bed, and just understanding that if I can increase the amount of intracellular calcium, intracellular sodium, I can now dig deeper and have a bigger contraction, right? So that's why we're looking at this. Please make sure that you're looking at what is happening to the levels of your sodium and your calcium as to your mechanism of action for digoxin. Which way are things going? Okay? I'm increasing those things so that I can squeeze harder. Okay? They're coming in. And then you see your AV node blockade that's happening, so you're having that parasympathetic effect that you have. So I'm slowing stuff down. This is a rate control med. What were my other two rate controls that I talked about? We talked about them before in our other blocks. Beta blockers are calcium channel blockers. Mostly everything else that we talked about today was dealing with rhythm control except for those. Now I have 3. My digoxin. Okay? So remembering if I have rate versus if I have rhythm. This is a picture, again, just showing how your digoxin is working. I know some people like pictures instead of words. So this has all of the different things that we just talked about. If I can increase that tone to help with the force from the contraction, I can therefore increase my cardiac output. Okay? So same exact thing that we talked about. Talking about also how it's going to slow that conduction that's at that AV node. So that's why when you're giving this, and if you give too much, this is a drug that has a narrow therapeutic window. If you give too much, you can see where I can experience heart block. I can kill someone because I blocked that conductivity from happening. Okay? So digoxin is a real old drug, but it can kill you. Okay? Clinical use, we talked about it with heart failure, and then we also are going to talk about it like right now when we talk about our AFib and our A-flutter. Because it can trigger that tachyarrhythmia and is shown to increase mortality in some of our patients who have heart failure, we want to try to maximize all of our other drugs before we put this on. That's why this was a part of our DAM. That's why this was a part of that class 5. Okay? I'm not getting any real benefit from it. I have a lot of monitoring that I have to do when I have this drug on board, so I'm going to keep it down at the back end. It has a lot of interactions. The digoxin is a great drug, it's a pain in the butt. Okay? So you're using this as like, hey, I've maxed them out. You know how we talked about maxing people out in our last block. I've maxed them out. Now they're still symptomatic. I'm still not slowing things down enough for them. Let me see if I can get some digoxin. Okay? Looking at our PK parameter, we have good distribution. Half-life isn't too bad. What we're worried about is our elderly patients, because remember that creatinine clearance starts to dwindle away, right? I'm not clearing things as well. So now, with my narrow therapeutic index drug, if I'm not excreting it enough, it's accumulating. And now I am more likely to have a lot of issues and potentially toxicity if you're not monitoring this drug closely. This is what we were looking at with me telling you about the narrow therapeutic index. So you have different targets that you're looking at, typically between 0.5 and 1.5. And when you go outside of this range, you are likely to see toxic symptoms occurring. Your patient is going to complain of several different things. Medication-wise, and like what dose you're starting your patient on, look them up, but typically we're starting low. You'll see that we'll do like that 0.125 to 0.25. Like you're starting low, seeing how your patient is going to respond because they're already on their other medications. You're just trying to get them to not be as symptomatic. Okay? So this is not a drug that we want to use a whole bunch of. This is not like my primary first line, I'm leaning on this. This is me adding this to get my symptoms under control for my patient. Okay? So that's where you see that it must be individualized. Elderly, smaller patients, right? They're going to need to be definitely on that smaller, lower dosing range, so that 0.125. And then you see that we're going to make sure that we're watching out for those labs to make sure that we are within that therapeutic window. If you start to see it creeping up, then we need to back down on our dose. Okay? So we do bring people in to monitor for this very frequently. Looking at our monitoring. So we have the DIG levels that you're going to monitor, right, to make sure that they're within that normal therapeutic range. Make sure that you're waiting at least 6 to 8 hours after you've given that dose, because we need to make sure that it goes through all of our ADME stuff that we talked about so that you're actually getting the peak of the drug. You take it before, you're going to get a false level of where you're supposed to be. Okay? So at least 6 to 8 hours after, you're looking at ECGs, you're looking at their electrolytes, a lot of monitoring. BUN, creatinine, lots of monitoring goes into this drug, okay? So I tried to pull out everything that I want you to focus on, and it's in purple. The one thing that's not on here that's also very important that I need you to write in is if their heart rate is less than 60, you're not going to start this. Because I'm going to slow them down even more, right? So now I'm adding an additive effect to that bradycardia that they already have at baseline. I add on this drug, they're gonna tank, okay? Our adverse effects, we have some very mild symptoms that we're typically gonna see whenever we're using this medication, our basic stuff, right? Nausea, vomiting, headache. What's not typical is that we can have this rash and these visual disturbances, okay? Sometimes they will say like, oh, like it looks like I have like a yellow kind of hue over something, so that's that visual disturbance that you'll see, or they just can't see well, like they start to get disturbed. What else did we talk about today that had visual, we needed to monitor for visual? The optic neuritis. Starts with an A. You have to worry about their lungs, amiodarone, right? So looking at that, like trying to connect y'all, like, I don't know, just tell us the answer. Trying to make it think a little bit, but make a note so that when you study it, you can be like, oh, these two things, it's one of these two things. Now, when we look at our toxicity, right? When you get over 2, you in great boo-boo, okay? Not good. We're worried. We are worried. So this is where you start to see those pro-arrhythmic effects starting to happen, right? So I see I can have tachycardia, I have all of these different types of arrhythmias that can occur because I had a narrow therapeutic index. I had a narrow therapeutic window, and I went outside of it, okay? The higher that I go outside of that, the more likely I am to potentially kill my patient, okay? So our signs, you see bradycardia, those vision changes that we talked about, the yellow hue, the halos that they're saying. A lot of your patients will be very disoriented. So just paying attention to those things, having them and their family pay attention to those things is also very important because you're not always going to be around. You're not always going to be very accessible to them. Sometimes you're going to have to be like, hey, you need to go to the ER, right? Because if they try to make an appointment with you, it's going to be a couple of months. They'll be out of there by then, okay? And then the same things that we talked about before with our increased risk, right? We talked about our potassium and our magnesium. If those are low, we're worried about that. And then, of course, the older we get, if we have any issues with our renal function, which typically declines with our age, that's where we're worried about that accumulation. That's where we're worried about potentially being outside of that therapeutic window. Is it saying that that's a contraindication? It's not saying it's a contraindication. It is saying that you need to monitor these patients and then you can adjust your dose to get within that target range that you're supposed to be in. It's going to be a lot more work in those populations, but it's not necessarily that you're necessarily saying that you can't. When we're looking at our hypokalemia here, when we talk about digoxin, it doesn't cause hypokalemia, but it can cause us to have hyperkalemia because of the displacement that is occurring. So just remember these electrolytes and which way they're saying if it's hyper versus hypo. So hypokalemia and magnesium, right? So hyper K, hyper Mg, and then hyper with your calcium. So 2 hypos, 1 hyper, okay? I have a question for y'all since we just went over the block. What are some of the meds that we had where we said they could cause hypokalemia? Because it's a diuretic. It's a certain type of diuretic. Right? So we have our loops. We talked about our loops. We have potassium sparing, right? All of those things can mess with my potassium. So if you have any drug that you're thinking about that can mess with your potassium, we should be watching out for those, right? Because I can potentially make things worse for my patient, all right? So I'm definitely looking at like my loops, I'm giving it a little side eye. Looking at your interactions. If I am having somebody who has antacids, now they're a problem for us again, right? Because now I can decrease the absorption for my patient if they're taking any type of antacid. When we look at some of our laxatives or our cholestyramines, those aren't absorbed very well, so they can get in the way of our absorption of our medication. So that's why you see the decrease in absorption. With your increase in your concentration, you can see that your macrolides, your antifungals, your 1As, and your cyclosporin, tacrolimus and verapamil can increase your doses of your DIG. So digoxin is just all over the place, right? It is interacting with so many different things. So a lot of times whenever for you and how you're dealing with these patients, if you see a patient who has digoxin on when you're doing their med rec, you need to be like, all right, if you're gonna prescribe something else, let me go type this into an interaction checker to see if it has an interaction with this digoxin. Okay? That's what I want you to remember because there's a lot of interactions. Looking at our drugs that affect our potassium, this was what we were already talking about, and then we already went over several times all of our other meds that are gonna slow down our heart rate, and we're gonna be worried about bradycardia. Yes, ma'am.
What do you usually check for interactions? Do you have like an app that you mentioned before?
So you know LexiDrug,
Lexidrug?
you can use that. I think drugs.com has one that you can download on your phone for free. That's pretty good. So like, I like LexiDrug better because it's more, like I just feel like it's more professional. I feel more legit with LexiDrug. But yeah, they have lots of different apps that you can use, and I typically, I use LexiDrug for all of the interactions. You can type in all of them, and then it pulls up the interaction, and it puts all the ones that you can't use first, and it tells you even why. Sometimes it will tell you what to do to fix the problem on some of them. Okay, my contraindications that I have with my digoxin. So when I'm looking at this, if I have my person, they're in BFib, if they're already bradycardic, these are the same things that we keep talking about. If they're experiencing hypokalemia, the reason why we're talking about that, remember the mechanism that we talked about with our digoxin, right? I was worried about my sodium, potassium, ATPase. So if I have low levels of my potassium, or if I'm affecting my levels of potassium, now I'm affecting what's happening with my pump. Okay? So that exchange is not going to be the same that I'm typically expecting for it to be. So if I have low levels of potassium and my sodium and my calcium are up in the cell, I'm looking at what is going to happen to my potassium pump. Do I have enough to pump out versus what I'm pumping in? And I'll do an illustration of this. We'll go over it again tomorrow, and I'll try to do an illustration to where we can kind of see why we're worried about our patients who have hypokalemia. They don't have enough to exchange, and therefore we have issues with our sodium potassium ATPase pump. So looking at my electrolytes here, my potassium is competing with my digoxin for my pump, right? So I have these two things that are now trying to compete. Remember sophomore semester when we talk about trying to bind to something if we have competition, right? So now we're trying to see who can get there first. So if I have hypokalemia, that means my digoxin there's no competition, right? There's no potassium there for me to even compete with. So now I can have more of my digoxin binding to that pump, and therefore I'm going to see increased effects of my digoxin. So that's where you see hypokalemia. I have increased digoxin binding, and therefore it enhances its therapeutic and toxic effects. Okay? I need y'all to remember this concept because we overlook this a lot with our patients who are on the top. Now, if I have hyperkalemia, now my digoxin is having to work. Okay, you don't like that. Now I have to work. There's competition. So therefore, now I am seeing decreased effects in my digoxin. It's not doing what I want it to do because I have too much potassium around here trying to get into my ATPase. It's blocking. Okay? So make sure you understand what's happening and that you're having more pro-arrhythmic effects when you don't have enough potassium around. That hypokalemia is more dangerous than your hyperkalemia. So that's why it is a contraindication with your hypokalemia. Because now I'm having an increased effects in my digoxin. It's going to slow things down too much. Okay? Pro-arrhythmic. Now, what am I going to do if my patient is overdosed on digoxin? How do I help them? Am I like, oh, yo, Dad, I'll watch you on your way out? No, I have Digibind, or digoxin immune fast. Okay? So I'm going to tell them to stop taking their medication, and then I will give them the digibind, and the digibind is essentially doing what it sounds like. It is trying to bind to that digoxin to make it to where it's not available to actually act on the body anymore. So it's not gonna slow anything down anymore, right? It's gonna bind to the digoxin to take it out of play. Remember, when we bind to stuff, we're in a committed relationship, we stuck. No action is happening, okay? So I stop my medication and then I give them digibind. That is your antidote that you have. Remember that I still have to look out for this potassium. When you think about digoxin, just think about your potassium, because it is just all over the place. It's always messing up with what we have going on, okay? It won't let us be great. So monitor your potassium levels, because you can get, it may cause hypokalemia. So essentially what happens is sometimes you'll see a decrease in the potassium levels because they will shift back into the cell. And sometimes that can increase their risk of mortality and morbidity because of that shift of the potassium that happens. Adenosine. So adenosine is a cool little drug. I got to see this working. Make sure you're looking at the mechanism because it's not grouped like all of our other ones. So here you see that we have an increase in our potassium efflux and then a decrease in the amount of calcium influx. Okay? Remember that our calcium was in that phase 2, and that's where we were kind of like talking sometimes about like our calcium channel blockers and things like that, which was our class 4. So just make sure that you're looking at your mechanism and what's working and which way are these ions going is important. So ultimately what you have is you're going to be slowing things down. Now, when we talk about using this, I told you this is a real cool little drug. So drug of choice for our acute cardioconversion. So we had a patient, he wanted to be cardioverted, and we needed to push the adenosine, and we did this in the hospital, of course, because it's the IV medication. And so you have to, he decided, yes, I want to try to cardioverter. I think he said that it was his second or third time where he had tried because he kept slipping out of his normal sinus rhythm. So again, they will monitor our patients, and we're going to go ahead and administer our meds. What's hard about this med is that it has that super short half-life. So they let one of the residents push it. And the patient was just looking at us and like nothing happened. So the doc was like, well, did you feel that? And he said, no, I didn't feel it. I'm like, oh, okay. So they doubled the dose and then they did it again. And the patient literally died. And it stopped everything because we were resetting essentially their heart. It's like turning on your on and off button. That's what your adenosine is doing. And he was like, oh, that hurt. And the doctor was like, oh, did you feel it? And I was like, why y'all ask us these questions? The man said it hurt, right? So the nice thing to do is to help give them like a little pain med or something, right? So that they don't feel that, right? Their heart restarting. But the big thing is that you have to make sure that when you're pushing this drug, you're following it with that saline. Because most of the time, because of that short half-life, it's dying in the line, so it doesn't get to our site. Remember, our drugs always have to get to the site. If I can't get to the site, I'm not working. So what was happening was they weren't pushing the flush fast enough, and so therefore the first dose, the patient never got it, right? The drug, the half-life, it was done, okay? So it's very quick. It's literally like turning off a switch and turning it right back on is what essentially happens, okay? So this, I want you to look at this dose to kind of just remember. So you do the 6, and then if the first dose isn't effective, that's whenever they doubled it, and then they did the 12. But it's still, you're still following them with that saline flush. So you typically will have those in your pocket when you're in phase 2, and you have them everywhere. And then as soon as you push it, it's like right after, one right after the other. So our adverse effect, basically, it stopped and just shut everything down. Their heart is going to stop. That was the goal. So that is, we're using this drug for the adverse effect that it is producing. And then, like I told you, our patient was like, oh my gosh, like it hurt, like the tightness. And then afterwards, he was like, I don't want to feel that again. So like the anxiety and stuff that kind of comes along with it. But because of it being a very short half-life, they don't experience this for a very long time. Like it's not that bad. And even with the flushing, a lot of your patients won't feel that flushing and like a warmth that kind of comes over their body as they'll describe it. But again, not something that is a very long time. Make sure that you're understanding that if your patient is on theophylline, that this medication may not work. Okay, that's the big deal that I want you to remember from this is theophylline, that theophylline makes your adenosine not work. Okay. Yeah, right. Have it, but I also don't see a lot of people on theophylline. Okay, your mag sulfate. So this is another drug that we will see kind of come up. IV-IM formulation. What you see here is your neuromuscular blockade. You have vasodilation, CNS depression. There are several different effects. A lot of the times when we talk about mag sulfate, we're talking about it in our pregnant population because of the eclampsia, and we're trying to stop like a seizure that they have is typically where we talk about this. But you can also see that it can help decrease that excitability that we're experiencing sometimes in some of our patients who have AFib, A-flutter. Our clinical use, all of these are listed here. Your eclampsia, pre-eclampsia. If patients don't have enough magnesium, we'll sometimes run this to like kind of replenish them to get them back up. Tocomyces and asthma, haven't really seen them used a lot in those situations. So just understand, like, it's here for us to use. This is our N and DAM, right? So we have digoxin, adenosine, and now we have our mag sulfate. Not good oral absorption. You see our adverse effects, more flushing, just like we talked about. We looked at our adenosine. You can have some more of that respiratory depression. You give too much of it. Now I've shot my magnesium up too high. Monitor those electrolytes, monitor that renal function to make sure that that drug, right, is not causing any other problems, that I haven't overcorrected. Your interactions that you have, because we have that blockade action of it, right, it's blocking that muscle. I'm worried about, again, my calcium channel blockers, my digoxin, and any of my other meds that could potentially depress the CNS, right? So think about this as like if it's a drug that I use for seizures, it's trying to calm down what's going on in the CNS. So if I have any other drug that's also calming down stuff that's in the CNS, I'm now causing more like delirium and like out of, like your patient is going to be more loopy. And then with your calcium channel blockers, especially looking at your DHP calcium channel blockers, you're going to see more of that hypotension, that flushing that we say is the adverse effect here. All right, let's see how much we can talk about our treatment real quick. So when we're looking at treatment, all I want you to know is that there's different types. I'm going to tell you what type, okay? So we have paroxysmal, persistent, long-standing, persistent, permanent, and reoccurring. When we're looking at this paroxysmal, for the most part, a lot of your patients are going to go back into normal sinus rhythm on their own, okay? So this is telling you your patient has AFib, they're not in normal sinus rhythm. These patients who are paroxysmal, they're in and out. Most of the time, you're not even going to know that they have it. Persistent, they've had it for longer than 7 days, whereas your permanent, they had it for longer than a year, okay? Or your long-standing persistent. Your permanent are your patients who said, you know what, don't cardiovert me. I'm good, leave me right here. I keep slipping in and out. I don't want to continue to go through it. I don't want to continue trying it. Those are your permanent patients. And then you have your reoccurring. This is just for terminology purposes. Okay, I'm not going to give you a patient and say, tell me which classification they fall in. This is just so you have an idea of why we're trying to cardiovert these people and if they want to be cardioverted. Okay? And then we'll go just talk about this real quick and then we're going to stop. So looking at your cardio, you have electrocardioversion and chemical cardioversion. When you're talking about electrical cardioversion, this is you actually like taking the pads, right? You're defibrillating someone. Like that is your electrical. I'm turning up, I'm like, okay, you know, shock. That is you actually cardioverting someone at that point too. Or I have chemical where I can take my medications and I can use my meds to try to get them back into normal sinus rhythm. Okay? Those are the two options that I have. There are some situations, and most situations, you'll learn this later, but we may want to anticoagulate our patient the longer that they have been in AFib. Because it was likely that blood has pooled and they have formed a clot somewhere. And the way that we are ensuring that they don't have a thrombus somewhere is that we will anticoagulate them, or we will do that TEE, which is the transesophageal echocardiogram. Your patient may tell you, I don't want you to do a TEE because it is invasive. You have to take the scope and you're going down their throat to see and looking at their heart to see if there's an actual clot. okay? So they may tell you no. If it's an older patient, we've had several older patients be like, absolutely not. I don't wanna undergo a procedure just for you to, like, so they'll just deal with the anticoagulation, okay? And then you may have to do it also after you cardiovert somebody, because what if I slip back into AFib or aflutters, okay? So just understand that as a part of your, if you cardioverse a person, we may need to anticoagulate them before and after that cardioversion, okay? We'll start here tomorrow.